Hey guys, my name's Sam and welcome to Prep Medic. This week's video, we're talking about chest seals, when and how to use them. This week's video is sponsored by Medical Gear Outfitters. They are a high-end medical supply company out on the East Coast. Totally family-owned, really good customer service. You can buy pretty much anything I'm talking about today in this week's video on their website. If you want to piecemeal your own kit and build it yourself, you can do that. If you want to buy a plug-and-play kit from them, you can do that as well. I'll leave a link in the description. Let's get back to the video. When we take a deep breath, our diaphragm contracts, creating negative pressure in our chest. This draws air through our mouth and into our lungs, where our blood is oxygenated at the capillary beds known as the alveoli. Now, if we have a penetrating injury to the chest wall that's at least 2/3 the size of the trachea, that negative pressure starts to work against us. As we take a deep breath, it creates the negative pressure, but instead of drawing it exclusively through the mouth down into the lungs, it's actually going to draw air through that wound, which is outside of the lung space and doesn't allow our blood to be oxygenated. This is known as a sucking chest wound or an open pneumothorax. And this is where chest seals come in. Chest seals are an occlusive dressing that go over a sucking chest wound, allowing the patient to breathe more effectively through their mouth. Now, although I have a lot of different commercial devices in front of you, and I do recommend these, the most expedient, most effective chest seal you have are your gloved hands. If you have help as you're going through your March algorithm and you identify a sucking chest wound, it's pretty easy to just put your hand over the wound as your partner gets a chest seal or a different occlusive dressing ready. Now, if you are by yourself, you might not want to tie up one hand doing that, and it might be better for you to reach for a device to stop that right away. I'll also mention that oftentimes, especially in a bullet hole scenario, GSW, you're going to have an entrance and an exit wound, and you need to make sure you seal both of them. So once again, you can take both your hands, sandwich the patient, covering the entrance and exit while your partner gets it ready. If you're by yourself, maybe move on to something else. So in front of you, I have a bunch of different commercial devices, and I definitely have my favorites, but most things on the market are going to work relatively similar. So right here, I have the compact hyphen chest seals. These are from North American Rescue, and honestly, these are probably what I use in 95% of my kits. And I use these because they are a relatively small form factor, but I found them to be very effective for patients. Now, the bigger the chest seal is, probably the better, just because it's going to seal a little bit more effectively. All of these work great in a classroom setting, but when you get a real patient that has a lot of blood and grime around the injury site, a lot of times these adhesives on the smaller seals won't work quite as well. So you can get a bigger version than this, and I would honestly recommend that if you can carry it. But a lot of IFAKs are relatively small. They're not necessarily our primary concern on our battle belts, plate carriers, or in our car, so I do understand if you go with something just a little bit more compact. So opening these guys up, they have a couple features I want to talk about, and they do all have directions on the back as well if you forget how to stick something to somebody's chest. So as we open this up, it's going to be folded, and you can already see how absolutely slimy they are. Now, this pad right here is to wipe off the patient's chest, get as much blood out of there as you possibly can. Now, on this chest seal in particular, you can see it has a valve. It has this star pattern right here. And that's to protect the patient against a tension pneumothorax. So a pneumothorax is a collapsed lung. And when they get tension physiology, it basically means that the lung is damaged. When they breathe in through their mouth, air is escaping into their chest cavity. When they had a sucking chest wound, some of that air could escape. It was a pressure relief valve. It really wasn't that much of a problem, even though it was making it harder for them to breathe. In a tension pneumothorax, once we seal that chest wound up, that pressure in the chest can build and build and build until you start getting what's known as obstructive shock. The lung essentially starts pushing over as the pressure in the chest increases, and it will eventually compress the heart, compress the great arteries, and kill your patient. So you have to be very careful when you put one of these on that you're monitoring the patient for further deterioration. And I'll be totally honest with you, the diagnostic criteria for a tension pneumothorax are pretty subtle. So a lot of times we will see these patients in the early phases of obstructive shock. They will start to get really tachypnic. It will be even harder for them to breathe. They're going to breathe faster and faster and faster. You're going to see a decreased blood pressure, increased pulse as they're trying to get more beats out with less blood. The problem with a lot of these symptoms is that they mimic a hypovolemic shock or a hemorrhagic shock, which is also a very real possibility in a patient that has been shot and has a penetrating chest injury. Some other symptoms you might see is tracheal deviation. This is a very late sign where the trachea starts moving over, away from the side of injury, and then you might have decreased lung sounds on that side. Although I will tell you, until that lung is totally collapsed, it is a very subtle finding, and you don't always hear it because you hear some echoes from the unaffected side of their chest. So the easiest way to treat this issue is to burp your chest seal. If you start seeing these symptoms, you just take the edge of the chest seal, you rise it up, and it will allow whatever air is trapped in the chest to escape the wound that is present. You can also go to a needle decompression, but honestly, if you have a chest seal over a sucking chest wound, just burp it. It's a little bit easier, a little bit less invasive. And just because you have a vented chest seal doesn't mean this won't happen to you. So even if you have a vented chest seal, you should still look at burping that seal first. Now, data has shown these laminar valves are a little bit more effective than some of the mechanical valves on some other brands. So that's one of the reasons I like them. Right here, I've got a simulated chest wound. I can just kind of show you how these go on. Red tab in North American Rescue products means that's something that you pull that'll move or open. So as I open this up, you can see how sticky that is. And I want to center the valve onto the wound just like so, put it over and pat it down. In a real life scenario, you'll see this valve kind of bulge up. You'll have blood coming out and it'll probably leak out the edges. That is all totally normal. And like I was talking about before, if you start seeing signs of a tension pneumothorax, it's just pulling up the edge, letting that vent out and putting it back down. Now, if you want to get really technical with the chest seal, you should wait until the patient exhales completely before placing the chest seal. That just makes sure that there's maximum adherence of the lung to the chest cavity and minimizes the amount of air that's trapped in there. So let's look at some other brands really quick, and I will also talk a little bit about improvising chest seal because that's something that is pretty popular in a lot of different EMT and first aid courses. So next we have this guy right here. This is a Halo chest seal. So they're, once again, a relatively common brand, and you can see it has the vent right in the middle. This is a relatively small vent, but you want to line that up with the chest wound right there, and it will seal the exact same way. Don't do this to your buddies if they've got a lot of chest hair and you're just practicing, because you're gonna give them a free waxing when you take it off. It won't be a fun time. And last right here, we have a IFAK seal. So IFAK seals are a little bit less common. I haven't really used them in the real world scenario, but I wanna show you guys kind of what some of the other things on the market are. And this looks like a non-vented chest seal right here. We have two. And we can just take this, open it all the way. Once again, super, super sticky. If you only have a non-vented chest seal, it's okay to use that. It's just one of those things where you have to be really careful about that tension pneumothorax. Burp this if you're even suspecting the potential for a tension pneumothorax. So these guys go on pretty well, and then it'll just stay. And obviously you can take it off pretty easily. Big shout out to TrueClot for sending me these trainers. I wanna actually try them out, hook them up to blood, see what that looks like. But it's pretty cool to actually be able to simulate it. Now, lastly here, I've got something that a lot of like old school EMS agencies are gonna be carrying. This is petroleum gauze. I hate using petroleum gauze. I just don't like it. It's kind of gross. It's just one of those old school things that refuses to die. And essentially what this is this is piece of gauze in here, and it's got like a bunch of jelly on it. Now, you don't use this by itself. They say like open the petroleum gauze packet, place it over it. The little bit of slime creates a seal on it, and then you can tape it. And this gets into kind of improvising a chest seal. So in class, I was taught, hey, take duct tape, take petroleum gauze or the wrapper or a plastic bag, put it over the wound, and then tape 3 sides, with the third side being, or with the fourth side being open facing down for your vent. In a classroom setting, this works really well. It's really easy to put that on your classmate and say, hey, this works. In the real world, what I have found is that it's very hard to get that tape to stick. You only have a little bit of adhesive there, where these have a lot more adhesive all over them. When it gets really bloody, the tape just doesn't stick. You end up having to put a bunch more tape over it, and it just hasn't been effective in my experience. Now, you definitely can do it. Just be ready to use a lot more tape than you think you need. As far as taping, not taping that third side, whatever, or fourth side, whatever's facing down, that's totally fine. That will work as a vent, because as air starts to try to come in, it'll suck the bag to it, and as air exits, it will allow it to come through that space. If you do have to just tape all 4 sides to keep it on, that's totally fine. Just be aware once again that you're gonna have to burp it a couple times. As it's related to chest injuries, the last thing I wanna talk about is an entrance and an exit wound, like I talked about before. So entrance wounds, when we're talking about gunshots, are oftentimes going to be pretty small holes. Believe it or not, they can oftentimes be hard to find. The exit wound will sometimes be a little bit bigger as that bullet expands, as that cavitation occurs inside the tissue. You can have a bigger wound in the back or wherever that bullet came out of. So just be aware of both sides and make sure you're sealing both sides. So chest seals do have a couple off-label uses that I want to talk about today. First and foremost is going to be using it to prevent an air embolus in a severe neck injury. If we have a gunshot wound or a knife wound to one of the great arteries in our neck, it's very easy for that to suck in air. So after we pack that wound, we stop the major bleeding, it's best practice to throw some kind of an occlusive dressing over it. Once again, this is something that works really, really good in a classroom setting when you're using a wound packing trainer. You pack it up all nicely, the bleeding is stopped completely, you put a chest seal over it on their neck, and you're stopping air from entering. Works really good. In reality, we're doing a lot of wound packing. There's a lot of blood around it. If you are able to throw that chest seal on, excellent. But just because the chest seal is there doesn't mean you're going to release pressure. That chest seal will be the last layer. You're going to place that on it, and then you're going to hold pressure with your hand as hard as you can against their neck for as long as is feasible. If you're in a dangerous environment, you can wrap it with some kind of circumferential dressing. A lot of times we'll take a trauma bandage, put it up there, and then we'll wrap it around their armpit, have them lower their arm. That'll hold it in place, but once again, that is not ideal. The second use for chest seals is going to be severe abdominal injuries. Abdominal gunshot wounds or any kind of impaled object or evisceration, this is not a compressible hemorrhage. We're not going to be doing a ton for bleeding control in this region, but we do want to keep the site relatively clean. This is not a life-saving technique. It's more something to do when you have the time. If you do have penetrating injury to the abdomen, we can take a chest seal, put it over that hole, and it's just going to keep it clean and lower their risk for severe infection. The reality is they are going to be infected. This just keeps things kind of moist and nice and might help with pain slightly. The last thing I want to leave you with is a caution about chest seals. There is some data coming out that is suggesting these might not be as helpful as we once thought. It is still best practice, still standard of care, but there are some proponents going to not using these, especially if we can't monitor them for a tension pneumothorax, because we can cause a life-threatening injury if we're not monitoring for that constantly. All of that being said, if you have any questions, leave them in the comments down below, and I will see you next week.